Maryland for med school, and then did 2 years at the University of Texas, Galveston, 3 more years at George Washington University, and another 3 more years at the University of Mississippi. I moved back to the area this past summer and opened up my own practice in October, and I'm excited to be here. I think that had I not gone into medicine, I could have found happiness as a high school science teacher. I could have done that too, but also a high school history teacher. I had several excellent high school history teachers that kind of made things like a story, and I'm going to try to do that for you today. We're going to, basically, the topics you'll see here, I've done everything I can to keep it classy. There's one slide that's a little graphic, everything else is pretty much, kids could see and everything. But you'll notice a couple trends. One of which is that nothing is really fundamentally new. When you think you've done something new in plastic surgery, it's just because you haven't looked back far enough, because somebody else has done something similar. As the need for plastic surgery basically depends on people's situation. Is it that there's a war going on and people are being injured? Are people being injured in new ways? Are people suffering from diseases such as breast cancer and needing reconstruction, where before there was no treatment, so there was no reconstruction? You see part of that. And then, of course, people are living longer than age 30 or 40 in antiquity, and so people, of course, have interests that thousands of years ago they did not. The word plastic surgery comes from the Greek word plastique, which means malleable. The art of molding malleable flesh. And actually, the first evidence of any type of plastic surgery, I'm going to go back a little bit further than World War I, was found in ancient Egypt in something called the Edwin Smith Papyrus. The Edwin Smith Papyrus is written about 1500 before the Common Era, but is believed to be a transcription of something about 3000 before the Common Era. And it is inspired by military wartime experience. It is unique in that it discusses a rational basis for wounds and suturing wounds, bringing the edges of a cut, of a laceration together to increase speed, healing time, and also minimize disfigurement. It also describes repair of a broken nose. There's also descriptions of things like crushed vertebrae, eviscerations. This was definitely written by somebody who was familiar and experienced with people who were getting injured on the battlefield. It doesn't go much into stuff like, oh, they fell ill and then passed. Because I think when your experience is from the battlefield, well, they got stabbed with a sword, and now they have some blood bleeding. You don't have to explain things with magical thinking. You don't have to say, oh, it was the gods that stabbed the guy. No, it was the other guy from the other side that stabbed him. The first person who is known to have an alteration, we can call it a plastic surgery, was actually Ramses II. Ramses II was a pharaoh of ancient Egypt, and he was known for a very prominent nose. And in ancient Egypt, the face was considered central to the soul. If you did not recognize the face in the afterlife, this would cause problems for you. The mummification process results in some of the prominence of the nose decreasing. So when they inspected the mummy of Ramses the Great, they found little pieces of seed and bone to kind of recreate that prominent nose he had in life in the afterlife. There's also evidence of a queen that had what we would consider today cheek implants, prominent cheeks in life. Well, in the mummification process, some of that went away, and so that was augmented for her good looks in the afterlife. The first plastic surgery operation we can describe was actually first described in ancient India, about 600 before the Common Era. And this was done because supposedly, at the time, it was not uncommon that the punishment for certain crimes was to have somebody's nose cut off. And so you have a population of people with parts of their nose that were cut off. And some of these people, at some point, obtain the funds one way or the other, and they say, I want something done about this. I don't want to continue to walk around like this. And so Suchrata was a physician that categorized the reconstruction of the nose by using a piece of the skin from the forehead folded down. This illustration is from a Gentleman's Weekly magazine, which was popular in the 1800s in England. And so it was considered novel enough in England to publish it there, while it had been already known for several millennia in India. Now, interestingly, this is actually very similar to a certain modern technique for nasal reconstruction. This is from a modern textbook, where now the flap of skin does not come off the midline, but off the paramedian, right off the midline, because we know that there's blood vessels that come up here, the supratrochlear and supraorbital vessels. And this is something that's used today, actually, for total nose defects, for things such as skin cancer and whatnot. In medieval England, there's a document that was discovered, Bald's Leech Book from the 19th century. It describes many treatments for a variety of medical and surgical ailments. This is a description. It prescribes surgery for cleft lip and palate. So there's becoming a distinction here that certain things are surgical problems, other things are medical problems. It describes a solution for impotence. A certain type of seed, ground and boiled with milk, would cure even the worst impotence. But it says that if you boil the seed with Welsh beer, it causes the exact opposite effect. So you gain little insights into what is important of the culture and people's prejudices of the time. Tagliacozzi in Renaissance England had a problem that there was a lot of dueling going on. And if you survived the duel, sometimes it's because you were only disfigured because you got hit in the nose. And so there was a lot of, or enough of, Renaissance Italian men walking around with disfigured noses or lost noses after duels. So he figured out this contraption of trying to get skin from the arm to be kind of attached onto the nose. Now, the downside of this is obvious. You have to have this contraption to try to keep your arm like that for a fair amount of time, probably months, okay? Today, you could still do this if you so wanted to. It would probably take about 3 weeks, and today we really prefer the Indian method from the forehead. In 17th to 18th century Europe, we find this. We find plated material for nose reconstruction. Obviously, the nasal reconstruction of the time is not perfect, and so there is also a trend towards using prosthetics to try to camouflage defects. Obviously, an alternative to surgical reconstruction. The downside, of course, it can fall off. And the color is, well, if you're a European, there may be some color mismatch. You may have to explain. The first real textbook of rhinoplasty was written by a Prussian army physician in 1818, rhinoplasty. Once again, we have the inspiration of injuries on the battlefield and how that inspires a solution to in the surgical theater. And this is actually a page from the book describing a phenomenal result of nasal reconstruction. We are still at the point of reconstructing war wounds. Interesting also to note is that even in this era, von Graf gives the impression that his nasal reconstructions are absolutely perfect, as a diagram is, well, easy to make quite perfect. Interestingly also, German is a guttural language. You need an intact soft palate and hard palate to speak German. And he also described some of the other more first modern operations on a cleft palate. Not the first one to say it's a surgical disease, but really kind of finessing some of, kind of getting to some of the more finesse. By the way, if anybody has any questions, I mean, this is a small group, you know, just raise your hand and I'll be happy to answer them. These are some other diagrams from Ramos Plastic. Well, look, the Italian method of nasal reconstruction has not completely fallen out of favor. And look what he also has in here. He also has the Indian method of using a piece of skin from the forehead pulled down to try to reconstruct a total nasal injury. This is, of course, the time before antibiotics, when sometimes whiskey was the best you could get for an anesthetic. So it's a difficult, trying time. It's amazing people are undergoing this. Diefenbach, in 1848, he's a German, or a Prussian, technically. He has military experience. He fought in the Napoleonic Wars. But at this point, he's a professor. He's a civilian at the University of Berlin. And now he is describing the first, in his textbook manual, reoperation, not to reconstruct, but to improve the appearance of a previously reconstructed nose, hinting two things. One, the previous reconstructions were not perfect, and second, that surgical technique and risk was beginning to tolerate revision operations. Once again, before antibiotics, before modern anesthesia. Well, the Americans aren't left out of this. John Rowe, from Rochester, New York, at this point a civilian, clearly, starts talking in 1887, the deformity termed the pug nose and its correction by a simple operation. I'm not sure if you can sense Dr. Rowe's ego. He clearly thinks a lot of himself. And of course, here we have a diagram of a nose that some may consider less ideal, and another nose that some may consider more ideal. What is quite unique, though, is that he's describing the approach, a kind of a modern approach to nasal defects, which is going through the inside of the nose rather than the outside of the nose. Now, one of the critiques, of course, is, well, you're just, Dr. Rowe, you're just publishing about, like these diagrams. I mean, we've got good illustrators too. We can, draw all types of things. So in 1891, photography is now more common, of course, or it's coming into vogue. And this is the first cosmetic plastic surgery patient who had her or his picture published in the literature. And then, so he describes the taking down the dorsal hump result, which is a great result, really, through an intranasal approach. And today, the surgery would be done very, very similarly, except with antibiotics and anesthesia. At this point, there's now ether is around, chloroform is starting to come out. Ether is a great anesthetic. I've never used it because it has a problem. It's quite flammable, so it's not used anymore. But these are, the risks people are willing to undergo to have something a little different. In the 1890s, see, this is not new in 2016. World War I transformed the world and medicine like perhaps no other event. There was trench warfare came into play. I still remember from high school history that this was the idea, the thought was that, that if you just had a little bit more men, then you could have taken that extra quarter mile of terrain and so forth. And of course, people spent months in situations like this. Their feet are wet, cold, they're getting gangrene, and their heads are exposed, or to flying bullets and shrapnel, or if they're trying to see what's going on, the head is what's going to get hit. Sir Harold Gillies was a New Zealander who was a physician in the British Army. and he started treating these facial wounds. These patients were now starting to survive wounds that before would kill people, and also the mechanism is that they're getting shot in the face more preferentially. And so he basically, literally just started making things up and trying to figure out what would work. Literally experiment, because that's all he kind of could do. He ended up with a unit of a hospital dedicated specifically to facial trauma. Today we might have a unit of a hospital dedicated to heart disease, to cancer. Well, he had one dedicated specifically to facial trauma. He outgrew it, then got his own hospital of 1,000 beds. To give you Fairfax Inova has about 1,000 beds. Every other hospital in this area is probably smaller. Washington Hospital Center in DC, that has probably about 1,000 beds. Most hospitals around 300 beds. So, large amount of beds, an entire hospital dedicated to facial injuries. Quite unique. He performed 11,000 operations there on 5,000 patients, so we know that most patients were receiving more than one operation, many of them receiving multiple operations. Interestingly also is the name of the hospital. It's not the little hospital in the forest on the hill. This is the Queen's Hospital, indicating the significance and importance of these type of injuries to the time that a name such as the Queen could be given to a hospital that just did one thing. This is Sir Harold Gilley's first skin graft. This is, in fact, I did a skin graft earlier today. Not this type, a little different. Not for this type of injury, but for something different. I can't go into the specifics, but this patient was an airman. His plane crashed, and he suffered burns. He suffered facial burns. And so, in addition to disfiguration here, what I can tell you is that with the loss of soft tissue, he's not going to be able to close his eyes well. And if any of you have dry eyes, that's a very difficult thing to live with. If you have dry eyes, if you can't close this at all, that can result in even corneal ulcers and potentially blindness. Furthermore, this is of course painful. The scar is going to be thick. He's going to have limited ability for facial expressions, limited ability to kind of move his mouth. So Dr. Gilley's thought was to excise, okay? Think about what you're doing here. No antibiotics, limited anesthesia, going ahead and excising all this scar, all that thick tissue, and replacing it with fresh skin that's not scarred, that hasn't been damaged by burns, okay? And this is the result. Not perfect, obviously, but you could say it's, for 1917, a reasonable improvement. And he started doing a lot of this.
Where was the source of the graft?
I don't know the source of the graft. The most common location, if I'm taking, this looks like a full thickness skin graft, I'll take it from the crease here, because people can usually still wear a bathing suit afterwards, or if it's a split thickness from the lateral thigh. But that's, I don't know where he would have taken it. You don't like to take it from, I mean, you can take it from the face, but then, you know, then you leave a big scar there. Taking it from the chest has some problems because then you're impeding abilities to breathe. My suspicion is that he would have been probably tended towards taking it from the legs, but you know, that depends. The other issue is color match. Skin all over our body is slightly different color. So if I'm doing a, you know, for like a skin cancer example, using skin graft for this area or for the nose, I'll take it from behind the ear or the front of the ear, as this is a similar skin color and thickness. But no, I don't know. Excellent question, but I do not know exactly where he took it from. From the way it looks here, the skin does look thicker, and obviously the color is quite different. But the face is, of course, you know, maybe the neck or something, but that probably wasn't available. Excellent question.
Thank you.
This is what Dr. Gilley's thought of as his finest work. And I took this from, this was on BBC. And this was a gentleman that had a gunshot wound to the nose, right? And so, returns of a major injury. What's interesting about the face is the face has very good blood supply, and so amazingly the face sometimes, you know, people can get foot infections and have that turn into gangrene, a lot of bad problems. But the face sometimes, especially in a young person, who may not have been able to afford cigarettes, which is a good plus, they sometimes actually do quite well, and the face can tolerate a whole lot more contamination than other places. But anyway, that's how, so anyway, this gentleman survives his wound. And so what Dr. Gillies does, I'm just think about how crazy this guy had to be, right? He takes a piece of, he makes an incision in the chest, takes a piece of rib cartilage. Now, we still use rib cartilage for reconstruction, but you know, if you end up in the lung, it's not good, but it's a manageable issue. I don't know how he would have managed if he got a hole in the lung and taking a rib. But he puts the rib up here, right? And then this is the old Indian technique, right? With the modern variation of using it off the midline. So he lets this rib kind of regrow, swings the skin all the way down, most likely put a skin graft back up here, and has this blob here for some time. Comes back a couple months later, after this tissue has reestablished the blood supply from the wound bed, and cuts this part. That's also nutty. Back in 1918, that's nutty, right? Well, except the Indians have been doing it for 2,000 years, so maybe not. And of course, long-term results are this in later life, in the 60s. So, and I think that's phenomenal. I don't think, you know, if somebody had a result like this today from this type of injury, I would take it. So this gentleman, Dr. Gillies, was incredibly talented, and this is, of course, we still have the name of who he was. Question?
Yeah, I was going to ask earlier, and it comes up again. On the old Indian method, what did they do to replace cartilage?
I don't know of them replacing cartilage. I don't know if they did or did not.
So the skin would be kind of no form to it. It seems like if you just use the skin.
Yes, exactly. So that is why modern, you know, in modern total nasal reconstructive surgery, so you have to replace 3 layers: the skin, support, and the mucosal layer. But hey, for 600 before the Common Era, you know, I think that's still pretty impressive. But obviously, what you brought up, Dr. Gillies would have been aware of the problem of reconstructing a total nose without support. This is an example of some mandibular reconstruction he did. This looks to me, you know, it's sad, but you know, unfortunately, you know, you do treat facial gunshots still in this age that look like this, sometimes worse. And there's just incredible loss of soft tissue. When this scars down, you have there's parts of the lip that aren't there, parts that aren't. And this was and he's trying to, what I can see he's trying to do with this is trying to prevent that scar contracture to occur. All wounds, all lacerations heal with a scar, okay? I didn't go to magic school, okay? But if you have a scar which is soft, supple, linear, not wide, that's great. There's just no way to have that with this, right? Okay? It's like 2/3 of the lip is gone, 2/3 of the mouth is gone. But here he's trying to prevent that scar contraction. We'll do similar things today in burn centers will be done, right? Where patients will be put in splints to minimize the contractures, look at on extremities. So that's what he's trying to do here. Later on, he tries to rotate some healthy tissue from the surrounding areas in, perhaps some tattooing and so forth, and long-term, quite a reasonable result. The downside of this, of course, is that the mouth is a sphincter, right? And you need a circle of muscle in order to close that and keep yourself from drooling. It's just not understood in society to drool. It's just not accepted, even if you can't help it because you've had a massive injury. And so my suspicion is this gentleman still would have had a drooling problem. The other problem would have been with articulation. There's certain things like, you know, I'll tell you, sewing up a lip, if somebody just cuts themselves straight down accidentally, it's very satisfying because before they can't pee, you have to put your lips together to say, I need to pee, right? They say, I have to go. But if you sew them up, then they can say, I have to pee, right? So the lips are important not only for eating, but also there's certain things you just can't say without lips. But anyway, but hey, he'll take it. So remember the Italian method? He's still trying it, right? And I don't know why it was chosen in this situation, perhaps patient preference or something. But Dr. Gillies got into these tubed flaps, right? This idea of taking, his innovation was that if you sewed the backs, so this skin is from the arm, right? And basically sews it into a tube. And if you sew it into a tube, the backside doesn't dry out, and skin will prevent it or reduce the risk of it getting infected. He attaches that to the wound up on the nose and has the guy like this for weeks or months while the blood supply from the face reincorporates into this from the arm and then would reattach it. So he became quite facile with these tube flaps. In fact, these tube flaps, you can even start to walk them. You can take, and they would start to do that and so forth. And they start to get quite aggressive with this because, hey, if it's working, let's keep going. Also remember, he's dealing on young, healthy patients. That's the other big caveat. This was a patient that, Henry Lumley really fundamentally changed Gillies' approach to traumatic reconstruction. This is, he's 18, he finishes up flying school, and on the day he's graduating, his plane crashes where he survives but sustains total face burns, loss of vision in the left eye, a partial loss of vision in the right eye, and this is kind of what he's left with. Also, you can see the scar contracture happening with the lips pulling the upper lip up, and that he's getting exposure for teeth and gums. So he went to, of course, Dr. Gillies' hospital, and Dr. Gillies came up with the surgical plan. And we still have his notes. He was going to create, he said, this is the face we have to recreate, and he was going to recreate a mouth, or a slit for the mouth, and then recreate the eyes. And this wasn't just skin, this is skin and subcutaneous tissue, right? So including some fat and so forth. And he was going to create these two pedicles, one on the right side, one on the left side. And literally kind of just like a mask, pick it up off the chest and put it on the face. So actually, I believe this gentleman was burned in August. He had his first surgery in October to create these little flaps. You can see them here. And then he had his next surgery scheduled for March, because Dr. Gillies did know that he needed to wait some time for the blood supply of this area to come from here. But he didn't completely know how it worked, which was evident, because this gentleman suffered all the skin, ended up dying, after he had gone resection of the facial injuries. Massive infection set in of the face as well as the thorax. No antibiotics, no intensive care unit. I don't think they could even do blood transfusions at this point. No electrocautery, which is a technique used to minimize blood. I mean, I'm just amazed that the guy thought he could even try something like this. And anyway, the patient did pass a couple days after due to infection, and his heart's not able to keep up with everything. And this is his tombstone that I found online, died in 1918. This, yes?
When you're taking the skin from, like, the chest area to the face, then what do you put in place of the chest?
So, you wouldn't do this in 2016, but if you are borrowing, you wouldn't do this exact operation in 2016, but if you were borrowing skin from the chest that was pedicled on a blood supply to reconstruct the face for, like, let's say, a throat cancer or mouth cancer, you would then use a skin graft. You would either use a skin graft, meaning borrowing a piece of split thickness skin. Anyway, so you borrow some skin from somewhere else to cover that area, or you try to use a place like, we all have a little extra skin on the chest, so you could perhaps just close that primarily. We have a lot of skin on the belly, you can close the belly primarily. Problems you have are the lower leg. Nobody has much extra skin here, so when people have like skin cancers or something here, you can't just do a leg lift or a lower leg lift and just pull skin over. So you have to borrow the skin graft skin from somewhere else. I don't know if that might be a little bit technical. I don't know if does that kind of answer your question?
So you take it from an area where you could then sort of sew it together in that area?
Exactly. For instance, let's say I was wanting to use a little neck skin. I mean, we all got a little. I got a little, right? Okay. So I could just take out a little bit of this skin, right? And I could just sew that together, right? Just snip, and it'll be a little tight on this side, but hey, we do it the other side. We got a little, so we can do that, right? There's certain situations, like if you have exposed bone, you have to cover that with soft tissue, such as muscle and the skin on the blood supply. There's certain situations where you can cover it with a split thickness skin graft. I should almost, I didn't think this would generate that much interest, but a split thickness skin graft is 1/14 of a thousandth inch thick, so very thin. It's like a bad rug burn, and you can use that skin to replace skin that you've lost. Now, it's not the full layer of skin, but the skin that you've lost, if you're using that to reconstruct somewhere else. So you're doing, it's kind of stair-stepped. So it starts to get complicated, and then you get all these permeations and all this type of stuff, and people like to go to conferences and talk about how they did something new. No, it's not new. They already did it. You're just doing it a little differently.
Yeah, I understand that there are now synthetically grown skin. You can take a piece of skin from somebody and then grow it in area.
Yes.
And then put it on the patient.
So I think what you're referring to is for badly burned patients. That's not something part of my practice, but I'm familiar with it. If somebody has, let's say, 95% total surface body area burns, what you can do is take a split layer, right, only the 1/14 of a thousandth inch thick, and you can regrow that and use that to reconstruct them. The problem with that is it's extremely expensive, and it's also not very durable coverage. Wounds have a tendency to break down with that, somewhat more so because it's very thin. The other thing which can be done is sometimes you'll use like a sharp cartilage mixture, which is used to kind of prepare a wound for skin grafting. Sometimes we use cadaveric skin from a tissue bank. We use porcine or pig skin as a temporary thing. Unfortunately, there's no, so those are like, there are some artificial ones. There's a product out there, various types of collagen and growth factors. There's sometimes even, like foreskin skin can be used. It's hard, people have thought of all types of wild things. But unfortunately, nothing really has replaced one's own skin, because you end up with issues of immunological rejection and so forth. So if you solve it, you'll do very well, and I want to be your friend. So. Anyway, so this was other questions. Yeah, go ahead.
Let's say it worked.
Yeah.
How would you make it so it closes its eyelids?
No reconstruction is perfect. You can't go back in time. You want to look 20 years younger? You can decrease some wrinkles. We can do that. So his goal might be to have a uniform skin throughout his entire face, to not have this kind of this wrinkliness, this disfigurement of the burns. If he wouldn't be able to close his eyes before, he may not be able to close them afterwards. I mean, this is the first thing you have to realize is this gentleman went through a horrific, horrible injury. And I mean, you just can't, there's certain things you can do, and there's certain things you can't do. Maybe to get him to breathe better through the nose, maybe things like that. So you try to focus on things that, what bothers you the most. It's the same whether it's reconstructive or aesthetic. Does that kind of? Yeah, no, none of us went to magic school, okay? Anyway, so this kind of really, and I think from this case, Dr. Gillies came up with the quote, and we still say it today: never rush to do today which can reasonably be done tomorrow. And so from this point, Dr. Gillies performed smaller surgeries, still did big reconstructions, but did them in smaller pieces. Well, World War II came along. So Gillies went into private practice and then went back into the service, and this time recruited his cousin, McIndoe, from another New Zealander, to come and help him. Now they had a hospital closer into London. And while continuing to do some of the techniques, penicillin was early getting on the scene, but one of the things that his cousin McIndoe, I think his big contribution, was the idea of reintegration, that people would go through these type of, very disfiguring injuries, prolonged operative times, prolonged recovery times, convalescent times, and they could be like this for weeks or months. And McIndoe thought it very important that people should still go out in the community, go out to the bar, go out, sit on the benches. He got the town involved. He got them to know, hey, listen, we're taking care of, injured servicemen, just, say hello to them and so forth. And you can kind of see pictures like this. This is McIndoe here with some of his staff and injured servicemen trying to enjoy themselves. And he was so inspiring and had such a big impact that the people who were treated by McIndoe and Gillies in World War II formed something that they called the Guinea Pig Club, because literally they were guinea pigs, but also because they had this sense of camaraderie that had fostered through their experiences. And they even had a song. We are McIndoe's army, we are his guinea pigs, with dermatomes, that's what's used for skin grafts, and pedicles, glass eyes, false teeth, and wigs, and when we get our discharge, we'll shout with all our might, per ardu astra, we'll rather drink than fight. And then it's interesting, the people, and they became attached to people. John Hunter runs the gasworks, Ross Tilley wields the knife, and if they're not careful, they'll have your flaming life. So there is a little bit of an indication that not everybody survived, right? And they're trying to cope with this through humor. So guinea pigs stand steady for all your surgeon's calls, and if their hands aren't steady, they'll whip off both your ears. So, and this is actually a real picture and so forth. I was lucky enough actually to once meet a patient of McIndoe's who had some ear reconstruction as a child, who was born without a fully formed ear, and he actually, and I was like, well, let me see how the ear reconstruction, he didn't really care about the way his ear looked. He was just so happy that he had been part of this. Of course, he wasn't drinking, he was like 3 at the age time, but, that's kind of McIndoe's contribution. So, we have people with skill sets and knowledge, and now there's a transition from war to peacetime. Once again, we think that 2015, 2016, people doing all types of crazy things, it's not new, it's just a little different. Laura Dillon, this is in 1946, made history. She was born Laura, went to an all-girls school, but always felt like a boy. Ended up working as a truck driver, watching for fires as a fire lookout, and in the garage in World War II. Somehow had the misfortune of falling and injuring her head, at which point she was brought to Sir Harold Gillies for some type of, whether it was something minor, right? And at that point had already begun taking testosterone, which another physician had used as a treatment for heavy menstrual periods. Once again, a lot of experimentation going on, not much oversight, but Laura Dillon wanted to keep going further. Harold Gillies at this time had a lot of experience, remember those tube flaps, making tubes? He also had experience with servicemen who had lost parts of their penises due to war injuries, through gunshots or burns or so forth. And so he now had experience making phalluses from these type of tubed flaps. And Laura convinced him and said, please, 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 I want it done. And in 1946 became the first had the first female-to-male bottom surgery. And that's the way lived the rest of his life as Michael. Actually went to medical school, became a physician, and wrote about endocrinology and sex hormones. Was found out at one point, had to move, and then had to move to India, tried to become a Buddhist monk and had difficulties, but he went through 13 surgeries with Sir Harold Gillies, and some of them were complicated by infections. And when he couldn't walk well, because of the infections, he just said, well, I just had an injury in the war, that's why I've got this problem, but Dr. Gillies is helping me out. So anyway, he wrote his medical book on endocrinology, which was read by Robert Powell, who, by 1950, was taking estrogen and started to live life as Roberta. Starts taking estrogen, starts living as Roberta, and reads Dr. Dillon's book, Self, A Study in Endocrinology and Ethics. Wants to undergo a testicular removal, orchiectomy, and it's an illegal operation in England at the time. So he can find nobody else to do it except Dr. Dillon himself, who performs the orchiectomy for Roberta. At which point, she is introduced to Harold Gillies, who then in 1951 on Roberta performs the first male to female bottom surgery. Assisting this operation in 1951 was Ralph Millard, who later was an American and later became kind of the pioneer of modern cleft lip and palate surgery. So interesting. It's not new in 2016. We've been doing it for some time. Talk a little bit about breast reconstruction. The first breast reconstruction I could find was from the 1800s. An Austrian surgeon who had a woman with a benign tumor of the breast, removed it, and had this wacky idea. Hey, look, she also has a fatty tumor down here. I'm going to move this fatty tumor from here to the breast. I'm just going to sew it up and put it there. Why not? No antibiotics. Well, see. And he published it. And, of course, that's the first one. There was other things that were being done. Breast augmentation is not new. There was an idea of being able to inject paraffin, right, a type of wax. So it's not just today people injecting weird type of illegal bad things in their bodies. It was done then, first time, actually on a man, because the man had, by an Austrian surgeon, a gentleman had lost part of his testes due to tuberculosis infection. And then later it was done for breast augmentation. The problem is that it works well initially, and then later you start to have chronic draining abscesses, and there's nothing that really can be done because this stuff is all over the place. I have a friend of mine who's a plastic surgeon in Colombia. There's a lot of off-the-shelf industrial silicone injections into buttock and all over the place, and and he says, and he just struggles with it because it becomes put in a three-dimensional place, and it's not like you can just take it out. It's everywhere. And then when it starts to drain, it's sorry, you now have to live with this. The most famous person who had to live with this, perhaps, was Gladys Spencer Churchill. She was a noblewoman, considered to be perhaps one of the most beautiful women of her day, socialite, and she wanted to have her nose augmented. And so she did with paraffin injection at the age of 21. The problem with this as well is paraffin also migrates and migrated down to her chin, and she, it's hard to find a photograph of somebody who doesn't want to be photographed, but resulting in a huge mass, prominent chin, and obviously this would drain and have problems. And she then became a recluse her whole life, had mental health issues, and really had a difficult time. Some people are still acting like it's 1890. This is from May 2016, illegal silicone injections, Maryland woman indicted. You don't have to go far to find these illegal services. I would recommend against them because they're quite problematic. We do have legal things which are studied and FDA approved. Collagen, we all have collagen. We all lose part of it with time. It just happens. This is a picture of somebody who's had a little bit of injection for a softening of their nasolabial folds. So can you make somebody look 20 years younger? No, but you can touch some little things, and perhaps somebody's happy with that. This is not permanent, so if you don't like it, it's not permanent. If you like it, well, it's not permanent. You gotta come back. Breast augmentation, once again, going back to this theme, we started with the paraffin and the putting one tumor into the breast and injecting with wax. This is the first patient who actually had a silicone implant, right? So a silicone implant is different than just illegal silicone because it is sterilized, it is medical grade, and it is also encased, okay? So it's not going, and it's in one spot, right? It's not all over. And she was the first person to have breast augmentation with silicone implants. People were using sponges, all type of other stuff. That didn't work well. But she had this in 1962. This is her before. This is her after picture. You know, people dress more modestly then. So today, perhaps you would, you know, the result would be more evident. But this is her now. She's in her 80s, and she still has her original implants. Obviously, there's been quite a bunch of progress in terms of implantation in that. About a quarter of all breast implants today are actually not used for aesthetic purposes, but for reconstruction. Breast reconstruction really started to get into its modern era in 1982 with the idea of stretching the skin after mastectomy. This is just, you think of pregnancy, you think, you know, the belly stretches and then it decreases, there's a little bit of extra skin, where you can do that on a mastectomy site where you place a expander or like a, you know, surgical type of balloon, and you expand it over time, and now you've got a place where you can place an implant. And a quarter of all breast implants in this country are used today. I was actually just in Dallas this past weekend, and they actually said that half of their revenue came from breast cancer reconstruction as opposed to aesthetic indications. 1982 was the first year also that what's called a tram flap was described. Now we talked Harold Gillies and, you know, the Indian technique of reconstructing noses. Well, this is just a little bit different, a little bit longer pedicle from the belly, under the skin, used for breast reconstruction, so reconstructing somebody with their own tissue. There's been many modifications. This exact is not done so much anymore because there's surgery, but the modifications live on and are still done. Most breast reconstruction today, however, is implant-based. Modern breast implants, the silicone is designed to be less flowing, so you can cut it open, it's not going to flow all over the place like the older ones. And now we also have shape implants to kind of create more of a restore for, especially our breast cancer patients, kind of a natural look as opposed to the kind of round bubble. Tried to find about the history of Botox and Dysport. These are kind of used for wrinkles or so forth. And initially was started, it took a long time to catch on. And the reason was, it was first found by the Germans in the 1820s. It was called Wurzgift, sausage poisoning, and it was known to be a very potentially aggressive thing in large quantities. In the 1960s, however, some eye doctors started to use minuscule quantities, like a millionth of an amount. Well, I don't know about a millionth of an amount, but much smaller amounts, small fractions, to inject in the eyes of cross-eyed monkeys. Okay? And they found that this could weaken the eye muscle so that the monkey could see better, actually. Well, obviously, it takes some time to get FDA approval for sausage poisoning to be used in humans, but in 1988 it was finally approved for ocular reasons. In 1997, some ophthalmologists noticed, hey, you know, when I'm using this for strabismus, patients are starting to lose some of their frown lines. And, well, a new world was born. Today, Botox, Dysport, they have FDA indications for many things. Some of them are crow's feet, these are the things on the side, or wolf lines from kind of squinting too much. It can be used on many other things such as bladder spasms, it can be used for muscular spasms. Another interesting indication, but actually I don't know if it's I'll scratch that, I don't know if it's on-label or off-label use, I can't remember, but it can also be used for sweating because it, you know, and sometimes people before they go for dance competitions, I mean, it cannot be like this. It just cannot. So, you know, that's what people do. People are very creative. The first facelift was, once again, I don't know why the Germans described all those things, but it was actually another German in 1901, but it was a Polish noblewoman who said, you know, can you just do a little bit, just a little, just a little, and just bring my cheeks up a little, just a little bit. And so did a minor skin excision. And that's how the facelift was born, 1901. Obviously, it's progressed quite a bit. First textbook of facial aesthetic surgery, 1907, right? And this is actually diagrams from it. How to create a dimple. So that's interesting that dimples were viewed to be important then. enough to be described. And the interesting, the name of the textbook, The Correction of Featural Imperfections. We perhaps would title it a little bit differently today, but 1907, nothing new. Modern reconstruction. I want to delve a little bit, we have a couple minutes, but I do want to delve a little bit into some modern reconstructive techniques. One of which is, we talked about, people's, fingers getting put back on, or so put back on. The next slide's a little bit graphic, but I think it's important to kind of see what this, what the result was. This is a girl that in India, in 1998, whose long hair was caught in a fan belt, and it ripped her entire scalp off. It also ripped the entire face off. Okay, and without this, she would end up looking just like one of those victims of burns. Well, this is what they did for her. The scalp and the face have lots of blood supply, and using a microscope, they're about 1 millimeter vessels. You can reattach them. It's not easy. It doesn't always work, but it did for her. Young, healthy patient, too young to smoke. This is her 3 years later. And you couldn't have, she's obviously got scarring, but there's no way that you could have gotten this with skin grafts. None way, right? And this was published. She's able to close her eyes because some of the musculature was intact or able to be reattached, or perhaps some of the nerves regrew. She's able to pucker her cheeks, right? So she's not drooling. And she's able to drink and she's not drooling. And so that's, and she lost her whole lips. She would not have been able to do this, right? So every single social interaction involving food would have been different for her had it not been for this replantation procedure. And this was done in India, okay? And so it can be done anywhere. It's not the first replantation, but I think it's the most graphic. Well, we also have a local contribution to history here in the DC area out of Manassas. I don't know if anybody can recognize this gentleman, but he is Mr. Bobbitt. It is not the first penile, it's not the first penile replant, but perhaps it is the most famous. And so the way this works is it's a clean cut, okay, and you reconnect the blood vessels, the urethra, kind of where you pee out of, as well as the veins. If you can reconnect under a microscope, they're about 1 millimeter. You're using sutures which are thinner than a hair, and if you can reconnect it and it works, it can work out quite well. And whenever I talk about the case of Mr. Bobbitt, I was not involved in it. I was still in school, obviously, it was many years ago. But and even my wife asked me, well, how did it work? And if you are so interested, he actually created a video, John Bobbitt Uncut, which you can find somewhere and perhaps look at your own leisure. It is not available at the library. I'm sorry to disappoint you. Yes, that's the video. Yeah.
Member was reattached. I mean, they found.
Yes.
She cut off.
Yes, it was not the. No, it was his. It was his. It was his, right? It was not somebody. No, yeah. Now it's not the first one. The first one was described in the first penile replantation was described in like 1927. In the 1970s, this was frequently tried in Thailand because at that point, I believe it was Thailand. There was a lot of it was Thailand or the Philippines, but it was somewhere in Southeast Asia where women got, there was in vogue that if you found your husband or suspected your husband of philandering, then out comes the knife. But anyway, so if you can replant a face after it's been ripped off, or a penis, you start to think of other things. So you say, well, can you do something else? And so actually the first face transplant, or partial face transplant, was done in 2005 by Lantieri's group out of France. And this was a lady, this is the way she looked beforehand. She had, I think she fell asleep next to her dog. There might have been some alcohol involved. I don't know the exact details. But this was her injury, total loss of lips. There's just no way to reconstruct it because there's no lips, right? And that's the way she healed. They did a partial face transplant on her from a cadaveric donor, and with makeup, right? Because she got to this point. I got to meet Lantieri, and I got to hear how they did it. It's interesting. They talk a lot about, interestingly, when you're taking the face from the donor. What you would do is, create a mask, right? So, and they would have like an artist, like kind of like create this incredible prosthetic so that the person could still have an open casket funeral, so the family didn't feel like there was something missing, as to helping with reacceptance. Just kind of some harvest, details. But the key is that the vessels have to be reconnected. And this is obviously a more extensive facial transplant done, I think, done by another group later. This is the publication of the first partial face transplant of how her lips move, and you see some of the nerves starting to regrow. And though she has asymmetry at 4 months at face, at 6 months she's got reasonable symmetry, being able to close. So there's much better study now, much more publication, and people want you to be more transparent, as they should. Yes, question?
Did she have feeling in her lips?
They describe as that she did have feeling. I'm not involved in that, so I don't know, but they did publish that she at least regained protective sensation, which is important if you put something too hot to your lips. Because if you can't feel that it's too hot, you're just going to burn yourself. She, of course, went through some episodes of rejection and so forth, but has done reasonably well. This slide's a couple years old, but a couple years ago, there's been more now. This is about maybe 4 years ago. At that point, there was about 18 face transplants. Nobody published the total loss of the face. But there was some opportunistic infections. People don't get unless you're on immunosuppressants. 2 deaths, 2 cancers. One person, I think, was in India, stopped taking their medicine. The other person had a very aggressive surgery that was more than the patient could tolerate. And of course, the other thing they mentioned is that with the transplantation of a face, since you're on immunosuppression, you might have 10-year shortened life expectancy due to immunosuppression. There's increased risk of skin cancer and so forth. Once again, so it's not the solution for everything, obviously. This is actually from our area. I got a chance to meet Mr. Robert Barron. Really, really interesting guy. He started out at the CIA making disguises for people so they could be a spy could go out and pretend to be somebody else, and camouflage, and it had to be so good that nobody would recognize them. Over time, he got into creating noses and ears and all that. This is from his website. Really great, fantastic guy, and he's out in Leesburg, and does phenomenal work. And this is a total face reconstruction with prosthetics. You can't match that surgically, I don't think. In terms of this type of appearance, maybe we will one day, but it just does phenomenal work for people without other options. Obviously, still blind, would still have some perhaps breathing issues through the nose, maybe the mouth doesn't, but you can go out to Starbucks, order a cup of coffee and just kind of sit there and listen and enjoy himself. So it makes a world of difference. Once again, not new. Remember the fake nose from the 1700s of Europe. So in conclusion, the reparation or the alteration of appearance or body parts is really, through plastic surgery, is not anything new. It's really ancient. We've started out with the Egyptians and the war injuries and so forth. And then also with the Egyptians, we saw the need for an improved appearance in the afterlife with nasal tip projection, cheek projection. The historical context, whether it's looking good for the afterlife, whether it's looking good after your duel or after being caught for stealing or some sort, or your life in the trenches or your life after the war, provides really kind of the context for innovation. Really, there's not that much new out there. A lot of it is just refinements of previous innovations. If you think you've invented something new in plastic surgery, they just say, well, you really haven't looked hard enough to see if somebody else has done it before. And then, of course, there's a trend towards increased safety, scientific study. A lot of these things that were done back then is saying, well, let's see if it works. You can't quite do that way today, and I think that's a good thing. Thank you.